So welcome guys. Um, in today's session, we'll be looking at primary hemostasis, which involves the formation of a platelet plug, and we'll be focusing on these three processes: platelet adhesion, platelet activation, platelet aggregation. Welcome all, my name is Oris Munyeri, and I'm the redactor. Now, let's start with what are platelets. Platelets are also known as thrombocytes, and they are small anucleate fragments of the megakaryocytes that adhere to exposed collagen on damaged endothelium. They adhere to the collagen on the subendothelial zone. Then they get activated and aggregate to form a platelet plug. Now, formation of the platelet plug is for others to primary hemostasis because it is the first response to bleeding. Okay. Then we have secondary hemostasis where we form a fibrin, the fibrin clot. Okay. Then you have other processes. Now, in normal adults, there are about 150 to 450,000 platelets per microliter of blood. Okay, they have a lifespan of 10 days, after which they are taken up by the liver and the spleen and destroyed. So that tells you that if you have increased function of the spleen in hypersplenism, you will have decreased platelets thrombocytopenia. Okay. Now, clinical laboratory tests usually measure the platelet number and activity. Okay, so this is your peripheral blood film. You can see a lymphocyte here. Okay, then you can see these small nucleate fragments. Those are your platelets. These are your red blood cells. Now, let's start with adhesion. Now, adhesion of platelets to exposed collagen at the site of vessel injury is usually mediated by the von Willebrand factor. So please understand the von Willebrand factor. Now, von Willebrand factor binds to the collagen, and then platelets bind to the von Willebrand factor via the glycoprotein 1B. Please understand that, which is a component of the membrane receptor complex, the glycoprotein 1B 5,9 on the platelet surface. Now, binding to von Willebrand factor stops the forward movement of the platelets. Note that if there is deficiency of the glycoprotein 1B, that is the receptor for von Willebrand factor, it will result in the Benard soulier syndrome. Okay, and in this, it is a disorder of platelet adhesion, so they cannot adhere to the subendothelial collagen mediated by the von Willebrand factor. Now, von Willebrand factor is a glycoprotein that is released from platelets. It is also made and secreted by the endothelial cells. Now, in addition to mediating the binding of platelets collagen, please note this, that von Willebrand factor also binds to and stabilizes factor 8 in blood. Remember, factor 8 is an accessory clotting factor in that it will associate with the factor 9, the activated factor 9, in the activation of factor 10, okay, in your intrinsic pathway. Okay. Now, deficiency of von Willebrand factor will result in von Willebrand disease, which is the most common inherited coagulopathy. Von Willebrand disease results to decreased binding of platelets to collagen and also a deficiency of factor 8. Remember, you need the von Willebrand factor to stabilize factor 8 in circulation. If you have its deficiency, factor 8 will be degraded. So those patients will have a deficiency of factor 8. Remember, also deficiency of factor 8. Factor 8 is also known as your anti-hemophilic factor A. So if you have this deficiency, they will present with symptoms which look like the classic hemophilia. Platelets can also bind directly to collagen via membrane receptor glycoprotein 6. Okay, please note that. But most of the binding is mediated by the von Willebrand factor via the glycoprotein 1B. Now, once adhered, platelet gets activated. Note this: damage to the endothelium usually expose the factor 3, the tissue factor thromboplastin, which initiates the extrinsic pathway of blood clotting and activation of factor 10. Remember, the factor 3 will form a complex with factor 7, and that complex is the one which now activates factor 10, okay, in the extrinsic pathway. Now, here we are, you can see this is the subendothelial collagen. So, von Willebrand factor will bind to the collagen, okay, then platelets will bind to von Willebrand factor via the glycoprotein 1B, okay, please note that. So, if you have a defect in this receptor, it will result in the Benard syndrome. But if you have a deficiency of von Willebrand factor, it will result in the von Willebrand disease. And remember also, von Willebrand factor binds to and stabilize factor 8 in circulation. Now, activation. Once adhered to the sites of injury, platelets get activated. Platelet activation involves there'll be two processes which are involved in activation. One is morphologic change in shape, then degranulation, the process by which platelets secrete the contents of the alpha and delta. The other name of delta is dense storage granules. Now, contents of this dense storage granules include calcium, okay, serotonin, and ADP. Okay, where contents of the alpha storage granules will be your platelet-derived growth factor, your factor 5, yes, such. Now, activated platelets also expose phosphatidylserine on their surface. Phosphatidylserine is very important. Remember, phosphatidylserine is negatively charged, and this externalization of phosphatidylserine is usually mediated by a calcium-activated enzyme known as scramblase, okay? But during normal process, when there is normal blood vessels, no injury, the membrane integrity will be maintained by enzymes known as phypases, okay? So, but when you have a vascular injury, we need the phosphatidylserine in a normal platelet is found on the inner leaflet of the plasma membrane. But during activation, we need to expose this phosphatidylserine, and this will be done by this scramblase enzyme. Now, thrombin is the most potent platelet activator. Please note that. Now thrombin, or your activated factor 2, remember factor 2 is prothrombin, the activated factor 2 is thrombin, binds to and activates a protease activated receptors. So remember, thrombin is a protease. Remember, the serine proteases are your factor 2, your factor 7, your factor 9, your factor 10, 11, 12. Those are your serine proteases. So these receptors, the protease activated receptors, are G protein coupled receptors on the surface of the platelets. Now, thrombin is primarily associated with GQ. Remember, GQ will activate phospholipase C. You know what phospholipase C will cleave the phosphatidylиnositol to release IP3 and DAG, but DAG remains bound to the plasma membrane. The inositol triphosphate will travel to your dense granules, stimulating a release of calcium, and DAG will activate your protein kinase C. Now, thrombomodulin, it usually binds to thrombin and thus decreases the availability of the thrombin for platelet activation. Thrombomodulin is an integral glycoprotein found on the surface of endothelial cells, and during normal processes, it will inhibit platelet activation from any thrombin produced. Now, let's look at these two processes involved in activation. I said degranulation and morphologic change. Now, degranulation, diacylglycerol produced from your phosphatidylinositol activates protein kinase C, which is a key event for degranulation. Then inositol triphosphate causes release of calcium from the dense granules. Then calcium will activate phospholipase A2, which cleaves membrane phospholipids, okay, to release arachidonic acid. Then arachidonic acid will be acted upon by your cyclooxygenes, especially in the platelets, COX-1, okay, to produce prostaglandin H2. Then prostaglandin H2 will be acted upon by the thromboxane A2 synthase to give you thromboxane A2. Now, thromboxane A2 has the following physiologic functions. Vasoconstriction, it also augments the degranulation and binds to platelet G protein coupled receptors, causing activation of additional platelets. So those are the physiologic function. Also, I've done a video on eicosanoids. We call that aspirin irreversibly inhibits COX, both COX-1 and COX-2. So consequently, thromboxane A2 synthesis, and it is referred to as an antiplatelet drug. Degranulation will also result in the release of serotonin and ADP from the dense granules. Serotonin will also cause more vasoconstriction. Okay, ADP will bind to G protein coupled receptors on the surface of platelets, activating additional platelets. Note that some antiplatelet drugs known as clopidogrel are ATP receptor antagonists, so they will inhibit platelet activation. Platelet-derived growth factor, which is involved in wound healing, von Willebrand factor. Remember, I told you von Willebrand factor is also released from your platelets, apart also from your endothelial cells. Factor 5, which is also an accessory clotting factor, and factor 13, your fibrin stabilizing factor, which is a transglutaminase, and also factor 1. Factor 1 is your fibrinogen, okay, are among other proteins released from your alpha granules. Now, note that platelet activating factor, which is an ether phospholipid synthesized by a variety of cells, including the endothelial cells and platelets, usually binds to the platelet activating factor receptors, which is G protein receptors on the surface of platelets, and activates them. So, the story I've been telling you has been summarized by this. You can see thrombin, which is a protease, will bind to the protease activated receptor, which is a GQ receptor, causing activation of phospholipase C, cleaving phosphatidylnyl to give you DAG and IP3. DAG will activate protein C, which will cause degranulation. IP3 will cause calcium release from your dense granules, which the calcium will activate phospholipase A2, which will act on the membrane phospholipids to release arachidonic acid. Arachidonic acid will be acted upon by your COX-1 to form a PGH2. PGH2 will be acted upon by the thromboxane A2 synthase to form the thromboxane A2. The thromboxane has the following physiologic function: platelet activation, vasoconstriction, will also augment the degranulation from the dense granules. We will get serotonin, which will also cause vasoconstriction, and also from the dense granules ADP, which will cause platelet activation. Now, from the alpha granules, you release your platelet-derived growth factor, von Willebrand factor, activated factor 5, and your fibrin stabilizing factor. I will show you where fibrin stabilizing factor will be needed. Now, morphologic change. Now, this is also under platelet activation. Now, the change in shape of activated platelets from discoidal to spherical with pseudopod-like processes that facilitates platelet to platelet and platelet surface interaction is initiated by the release of calcium from the dense granules. This calcium will bind to calmodulin and mediates the activation of myosin light chain kinase that phosphorylates the myosin light chains, resulting in a major reorganization of the platelet cytoskeleton. That is how the morphologic change occurs. You can see the unactivated platelet are discoidal, but when once activated, they become spherical with pseudopods, and these pseudopods will will facilitate platelet to platelet and platelet surface interaction. Platelet to platelet will also facilitate the platelet aggregation, which we are looking at now. Aggregation, activation will cause dramatic changes in the platelets that lead to their aggregation. Now, structural changes in the surface receptor, your glycoprotein 2B and 3A expose binding sites for fibrinogen. Okay, now bound fibrinogen molecules link activated platelets to one another with a single fibrinogen able to bind two platelets. So let me take a pen. Sorry for that. Take a pen. So you will see a platelet here and another platelet here. Then a fibrinogen with the one which will cross-link them, okay? And it will bind to the D dimers, okay, of the fibrinogen. Now, back the pointer. Where was I? Fibrinogen is then converted to fibrin by thrombin, okay? And then covalently constrict by the fibrin stabilizing factor, the transglutaminase, which will come from both the blood and the platelets. Remember, I told you that the alpha granules of platelets will contain your fibrin stabilizing factor, which will now stabilize that fibrin formed from fibrinogen by the action of thrombin. Now, the exposure of phosphatidylserine serine, remember I told you scramblase will disrupt the membrane integrity and cause the inner leaflet to be exposed, exposing the phosphatidylserine serine on the surface of the activated platelets will allow the formation of the excess. This excess complex is a complex of factor 8, activated factor 8, factor 9, and 10. And now this excess complex will convert factor 10 to factor 10 activated, okay? Activated factor 10, and also calcium will bind there, with subsequent formation of activated factor 10 and generation of thrombin. Remember, the factor 10 with the activated factor 10 usually initiates the common pathway. Now, fibrin formation, which is secondary hemostasis, strengthens the platelet plug. Okay. Now, we have rare defects in the platelet receptor. These receptors for the glycoprotein 2B and 3A for fibrinogen will result in a condition known as the Glanzmann thrombasthenia. Okay, which where there is decreased platelet fraction, whereas autoantibodies to this receptor cause the cause of immune thrombocytopenia. Okay, so we have some autoantibodies which attack these receptors for the fibrinogen receptor. Now, unnecessary activation of platelets is inhibited in 3 ways. One, an intact vascular wall is usually separate the blood from the now let me repeat that. Now, an intact vascular wall is separated from the blood by a monolayer of endothelial cell. So the sub-endothelial collagen will be separated from the platelets in circulation by the endothelial cells. So as long as that is intact, the platelets can't be activated. 2, endothelial cells synthesize prostacyclin and nitric oxide. These antagonize the actions of serotonin and thromboxane A2. Okay. Also, endothelial cells have the enzyme ADPase. Remember, ADP usually bind to a surface receptor on the platelets, activating a G protein coupled receptor, resulting in platelet activation. Now, if you have free ADP in circulation, they are cleaved to AMP by the enzyme ADPase found on the endothelial cells. So that is how you prevent unnecessary platelet activation. So here you can see these are your activated platelets. You can see they are cross-linked by a fibrinogen here. Okay. Then the activated platelets, remember they will release your fibrin. First of all, there will be thrombin. Thrombin will convert this fibrinogen to fibrin. Then fibrin will be stabilized by the fibrin stabilizing factor, factor 13. Or it is an enzyme, a transglutaminase, which usually form an isopeptide bond between the amino acid lysine and glutamine. Okay, so I think we have come to the end. So have you understood the platelets? Have you understood primary hemostasis? That should be your main concern, because next I will be doing secondary hemostasis. So you'll be looking at the extrinsic and intrinsic pathways. Thank you, and have a great time. Okay.